Thank you, sir, for the kind introduction. Good afternoon, all. I'm going to talk about sleep and diabetes, disclosure. So let's start with this slide, why we need to talk about sleep. Now, over 50% of people with diabetes report poor sleep quality, and poor sleep quality can affect glucose metabolism, hormones, and appetite. There is a bidirectional link between poor sleep and diabetes. So those who have poor sleep have a higher risk of getting diabetes, and those who have diabetes can have poor sleep. You can see some of the sleep disorders in diabetes: obstructive sleep apnea, insomnia, restless leg syndrome, and you can see the prevalence rates are pretty high. Modern lifestyle and shift work disrupt the circadian rhythm, and poor sleep is an independent risk factor for type 2 diabetes, obesity, and cardiovascular disease. Let's look at how lack of sleep can lead to diabetes. Now, first of all, there is increase in insulin resistance, and we know that when that happens, there's going to be increase in blood glucose levels. There's alteration in appetite hormones. There's increase in ghrelin, which is an appetite stimulant. There's a reduction in leptin, which suppresses appetite, and so there's going to be increased hunger cravings. People are going to overeat. They'll gain weight, especially around the abdomen, and that will again increase insulin resistance. There's hormonal disruption. There's alterations in cortisol, melatonin, and growth hormone, and that can impair glucose metabolism. Chronic inflammation, those who have poor sleep can have low-grade inflammation that will worsen insulin resistance. And circadian rhythm disruption will also impair insulin secretion and sensitivity, impairing glucose metabolism. Now, how does diabetes lead to poor sleep? One is nocturia. So we know that people who have high blood glucose levels have frequent urination. When that happens in the night, it leads to disturbed sleep. Neuropathy, that is pain. We've had patients saying that they have burning, pricking, tingling, disrupting their sleep. Obstructive sleep apnea, especially in those with type 2 diabetes and obesity, leads to intermittent hypoxia and fragmentation of sleep. Blood glucose fluctuations, especially hypoglycemia, can wake the patient up in the night, more of a problem in those with type 1 diabetes. Depression and anxiety are also common comorbidities in diabetes affecting sleep quality, and restless leg syndrome also more prevalent in diabetes, which can disrupt sleep. Now, when we talk about sleep, there are three foundational components. One is quantity, quality, and timing, and let's look at the association of each of these with diabetes. Now, here looking at sleep quantity and type 2 diabetes, multiple studies have shown that the ideal duration of sleep is 6 to 8 hours. So those who sleep less than 6 hours, called short sleepers, and those who sleep more than 9 hours, called long sleepers, are at increased risk of not only diabetes, as you can see, cardiovascular disease, hypertension, obesity, cognitive impairment, depression, and mortality. Among those with diabetes, irrespective of the type, those who don't sleep adequately will have worse glycemic control. Sleep quality is defined as the satisfaction with sleep experience, or in simple words, it's how well we sleep. Poor sleep quality has also been linked to increased risk of type 2 diabetes, increased HbA1c irrespective of the type of diabetes, increase in cardiovascular risk, and mortality. There are few attributes of sleep quality. First is sleep efficiency, that is the percentage of time asleep in bed, not the percentage of time in bed, the percentage of time we actually sleep in bed. Sleep latency is the time taken to fall asleep. Ideally, it should be around 10-20 minutes. Sleep duration is the total sleep time, and VASO is wake after sleep onset, that the minutes spent awake after initially falling asleep. Then you have timing. People are categorized into early birds and night owls, or morning or evening chronotypes. Those morning chronotypes go to bed early and they wake up early. Evening chronotypes go to bed late and they wake up late. And evening chronotypes have a higher odds of type 2 diabetes. Shift work also causes misalignment of the circadian rhythm, which is shown to impair beta cell function and increase insulin resistance, predisposing individuals to high risk of type 2 diabetes. And those patients with diabetes working on night shifts can also have worse glycemic control. Social jet lag. Social jet lag is sleeping at different times of the day. On weekdays, we may sleep at 9. On weekends, we may sleep at 12 o'clock, 1 o'clock. It's called social jet lag. And that also has shown to modestly increase HbA1c. Now, I talk about diagnosis. Now, history is very important. We need to ask about sleep duration and quality, whether they have any difficulty falling or staying asleep. Ask about daytime sleepiness or fatigue. There are questionnaires like the ESS, Top Bang, PSQI, which are very useful in screening for diabetic sleep disorders and also to assess quality of sleep. Physically, if you see somebody who is obese, has increased neck circumference, do think of obstructive sleep apnea. Blood pressure could be a clue to disrupted sleep. Those who have neuropathy could have neuropathic symptoms disturbing sleep. If there's edema, think of conditions like heart failure, which can again disrupt sleep. Objective tests include polysomnography, which is very useful for OSA and some of the other sleep disorders, actigraphy for insomnia and rhythm disorders, continuous glucose monitoring to look at nocturnal glucose swings, and sleep diaries. As for the labs, if you're suspecting RLS, do iron studies. If serum ferritin levels are low, do supplement iron. Thyroid and B12 for fatigue and neuropathy. HbA1c to look at glycemic status, and electrolytes if nocturnal symptoms persist, because certain electrolyte imbalances can cause cramps and other symptoms which can disrupt sleep. Coming to treatment, depends on the underlying disorder. If it's obstructive sleep apnea, weight loss is very useful. CPAP is the gold standard. There are oral devices for people who don't tolerate CPAP, but they're not as effective as CPAP. For insomnia, cognitive behavioral therapy works very well. It's effective in about 70 to 80% of the patients. So if somebody is saying they're not getting sleep, we don't have to jump into pharmacotherapy. There are non-pharmacological measures which can improve sleep. Regular schedule is important. Managing pain and avoiding stimulants late in the day. For restless leg syndrome, correct iron deficiency, leg stretches, massages, and warm baths will help. Medications can be used in severe cases. Nocturnal hypoglycemia is important. Adjust medications and add bedtime snacks if patients are getting low sugars in the night. CGM would be useful to look at their nocturnal glycemic profiles. So one point I'd like to highlight here is patients sometimes get hypoglycemia in the night, but they don't reduce their medication. So it's very important that when we give patients, especially insulin and sulfonylureas, to teach them about symptoms of hypoglycemia and how to reduce medications if at all they get hypoglycemia. So many times they get hypoglycemia, they don't do anything about their medication, and they get repeated hypoglycemia, which is very risky and can also disrupt sleep. Circadian issues, exposure to morning light is important, consistent timing of sleep, and melatonin in some cases. Optimizing glucose control is important, and don't hesitate to refer to a sleep specialist if required. So before going into my final slide, I just show you, this is from the ADA, highlighting the importance of sleep. And sleep is now considered one of the most important components of management of type 2 diabetes. It's now considered on par with other traditional lifestyle factors like diet and exercise. So you can see here the benefit in those with adequate sleep duration and quality in terms of reduction in glucose levels, blood pressure, HbA1c, and also improvement in quality of life, all with very strong evidence. So these are my key takeaway. Sleep disorders are common in patients with diabetes, and poor sleep worsens glycemic control. Both short sleepers and long sleepers are at increased risk for diabetes and other complications. Counsel patients on regular sleep schedules and screen time limits before bed. This is very important in today's era. Encourage regular daytime exercise and relaxation techniques for better sleep quality. Manage patient pain and nocturia proactively to improve sleep. Here, glycemic control plays a very important role. Nighttime hypoglycemia, as I mentioned, is a serious risk in diabetes and can disrupt sleep. Obstructive sleep apnea is highly prevalent but is underdiagnosed, so be vigilant, especially if you have type 2 diabetic patients who are obese, complaining of daytime sleepiness or fatigue. Do send them for a polysomnography. Refer patients to a sleep specialist if you think further evaluation is needed. And the most important takeaway in my talk would be ask patients about their sleep, because we ask about physical exercise, we ask about diet, but we don't ask about sleep. So make it a point that we always ask patients about their sleep. Thank you.